Will this do the advance? Oh, let's do it on there. Because I'm going to talk about drugs, I'm going to declare my relationship with industry, various companies, and I'm also going to say that I borrowed some great slides with permission from the great and good of the pain world. In particular, I'm going to look at Nice in 2015, where we had a NUPSIG meeting on neuropathic pain, and some really interesting data came out of that from the many people that were there. And this reflects some of that stuff that was going on there and that was important. Now, you all know that there are many world guidelines about the management of neuropathic pain. These are some of the guidelines. The pointer doesn't work, but you can see them up there. You got a pointer that works? You got a pointer at the back there? But these look at all the papers that there are and go through the best evidence and give us the advice that we have today. Yeah, it doesn't work. Ah, you didn't tell me that one. Oh, yeah. Well, that's much better. Got a button? Okay. Okay, so this is actually a typical survey looking at success rate with treatment for nerve pain. This is post-operative neuralgia, data on file. This is patients who are treated appropriately along a pathway that we just talked about with post-operative neuralgia. And actually, the interesting thing about this data was the GPs were asked if they treated the patient successfully or not, and they said, yeah, 75% success. And then you looked at the patients, most of them got no or slight pain relief. Very few had good relief. And if you asked about patient satisfaction with treatment, it was astoundingly poor, okay? Less than 10%, 1 in 10 patients were satisfied with their treatment. That is really, really bad, okay? That is not a good model. This was with informed GPs using a pathway. And then you look at the NNTs and you say, this is from FINERUP 2005, and we've all been using this model for 12 years, 11 years, sorry, and then last year it was revised. What they did is they took out negative trials, or added in negative trials, added in data on file, which is usually negative. This is what industry keep when they don't want to publish it. Took out duplicate trials, of which there's a lot, and I can do a whole lecture on that. And overall, they found, therefore, there was a reduction in efficacy. And actually, what they found was the new NNTs shift to the right, amitriptyline, massive for gabapentin, even capsaicin there. Really, 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 the NNT is going up hugely. Let's look at that again. That's incredible, isn't it? That's what we thought. That's what it is. It's about half as good as we were told. So it's not surprising, therefore, that our little patients here are getting nothing and the doctors are expecting something because our data was actually very flawed. So it moved from 4 for pregabalin and gabapentin to 7. And what was amazing, actually, was nobody blinked. Nobody said, wow, that's shocking. Nobody said, oh, I've suspected that all along. Just nobody sort of said anything. And, you know, this is NSAIDs and inflammation, and NT is 2. This is opioids and cancer pain, and NT is 2. 3 is okay, 4 is just about acceptable, and 7 is pretty unimpressive, okay? So what we've got at the moment, this is where we are. A substantial percentage of patients either fail to get satisfactory pain relief or cannot tolerate the side effects of their treatment. In people who do improve, there's usually only partial relief of their pain. Remember, these trials are to look at 50% improvement, not complete pain relief. And in those who are relieved, there are often limited improvements in functioning and sleep, which are really important to the patients. And the side effects of the many treatments that we give them are a burden in themselves to the patients. So they swap pain for something else. So actually, we're not doing very well. Why are the reasons for this? First of all, we all fall into the trap of thinking that all neuropathic pain is the same. We're not great thinkers, especially if you're like me, an anesthetist. So we just say, oh, they've got neuropathic pain, we'll give them amitriptyline, yay, great. Actually, treatment works differently in different groups. It even works differently in the same group, and there's some lovely work by Ralph Barron, which I don't have time to go into here, looking at subsets of postherpetic neuralgia and their different responses to different treatments, and showing that if you tease them out using QST, looking at hyperexcitability, allodynia, loss of sensation, you can get much better results. But can we spend the time on that? Also, recent trials in neuropathic pain have been disappointing. In fact, staggeringly disappointing. And the placebo effect, as you probably know, is increasing, especially in America. There's been a recent survey showing how the placebo effect's gone up, and as that goes up, of course, it makes it more difficult to have a significant NNT. These were three of the things that came out of the meeting in Nice, Leipzig. First of all, we need better diagnosis and classification of neuropathic pain. So we need to do SST on patients who are difficult. Secondly, we've got to promote earlier detection of pain, neuropathic pain, diabetic neuropathy, for example. Not so much us as pain specialists, but the diabetologists have got to recognize it earlier and control the diabetes more quickly and get on with things in that way. And the third thing is, are we measuring the right thing in clinical trials? And that's a whole another argument. We're actually going to have a meeting on clinical trials next year, but I suspect that we aren't. And we're using VAS and numerical rating scales of pain, and they're not a very good measure, and they don't reflect what the patient wants or needs. So we're probably doing things all wrong. So what should we do? I've just been terribly depressing about what we've got at the moment, but don't abandon treatment. It's better than nothing. We do get some benefits in some patients, but we have to understand the limitations of therapy. We have to target how to assess benefits. So when I see a patient, I don't just put them on a drug. I say to them, well, what do we need to improve? Is it the pain or is it your activity? Would you give up some pain if you could do this extra activity that you would find useful? Can we just improve their mood? And we start off with low dosages and we go up slowly. And we reevaluate over time. One of the most important things is that we have to inform the family physician what we're doing and how he needs to continue the management of that patient. And another thing we're now promoting in Europe is stopping medication if there's poor benefit or some tolerable side effects. Because again, I showed some data before about half the cost for pain drugs in Mersey region where I live is actually for pregabalin. Pregabalin? Yeah, half the cost. Beats morphine, all other drugs, etc., etc. And surely we can't think that half our patients in Mersey have neuropathic pain. Well, they don't, I can tell you that. And then we can consider therapeutic holidays. What else can we do to improve things? Well, we can perform rational combination therapy. We forget and we need to take into account psychological comorbidities. And what we're looking for in the future is looking at new compounds with a lower side effect profile or acting on new and novel targets. And also we need to look at responder profiles to drug treatments and probably look at detailed phenotypic assessment. Combination therapy, there's several trials showing that different combinations work better than the sum of the parts. Gabapentin and morphine are better than the two alone. Gabapentin and nortriptyline, gabapentin and venlafaxine. A lot of this work's been done by Gilron in Canada. And we also get some negative trials which don't show any improvement from adding them. So it's just something, it's very difficult to do a combination trial. It's just something that we need to look at anecdotally. Those are some other combinations that are commonly used, gabapentin and amitriptyline, either of those plus tramadol or tapentadol, and of course the gabapentinoid plus the lidocaine plaster. One thing that's not written about much or used very much is gabapentin and carbamazepine, which is actually completely logical, because gabapentin is a calcium channel blocker and carbamazepine is a sodium channel blocker, and both of those have a mechanism in many patients with chronic neuropathic pain, and we should use them together more often or at least give them a therapeutic trial. And that's not written about or done, really because nobody supports carbamazepine, there's no industry, nobody reminds us about it, so I'm reminding you now. But we need newer and better drugs with less interactions, less side effects. And we also need to evaluate some of the newer drugs that we've got at the moment, which actually aren't in these pathways. So tapentadol, the cannabinoids you're talking about here, botulinum toxin, capsaicin, those are available now and they all have an effect in neuropathic pain, and where are they in our treatment pathways? We actually need some good head-to-head studies in patients, and especially in the elderly, because the elderly are the ones I'm concerned about. Neuropathic pain is more common in the elderly, and they get a high burden of toxicity. So we really need to look at these drugs and see, are they actually better than what we're using at the moment? And if they are, we should use them more often. And I can tell you that none of these 4 therapeutic all in comparison with pregabalin in the UK and many other parts of Europe. Now, this is one of my slides that I've stolen from Nadine et al. This is looking at the central nervous system and looking at all the things that cause neuropathic pain, desensitization and hyperexcitability, gene regulation, central sensitization and inhibition of transmission, descending controls being affected, segmental inhibition, and microglial activation. So these are all things that we know can cause neuropathic pain, and they're all targets, and those are some of the drugs that we use at the moment and where they work within this pathway that we're going on to look at what new compounds we've got. So these are some of the ones, the horses, if you like, running in the race that we looked at about 5 years ago with NUPSIG. I'm very proud to be a founder member of NUPSIG and now an honorary member, and it's a good group, and we were looking at what's going to happen in the future, trying to prophesy. So this is a slide that was taken from a meeting we had looking at new sodium channel blockers, potassium openers, gene regulation, neurotropins, and anti-nerve growth factor. What about inhibition of transmission, the cannabinoid receptors, central sensitization, AMPA antagonists, monosodium glutamate inhibitors, calcium channel blockers, ziconotide is one there, and the novel, the new alpha-2 delta agonists like mirogabalin. And then we've got the GABA agonists also working here, microglial activation here with MAPK inhibitors especially being relevant in this area. And then modulatory controls, 2 drugs we've got at the moment, tapentadol and cannabinoid receptor agonists. And then going back out to the periphery and looking at desensitization of neurogenic inflammation, which is how we think Botox has an effect, and capsaicin as a possibility. So let's just follow those up over the years, because this in 2010, ralfinamide, which is a sodium channel blocker, was really, really exciting, and we thought this was going to be an absolute blockbuster, which was going to be great for the patient and also going to be great for societies like mine who depend on a healthy industry supporting us. So we were all very disappointed when the first trial came in and couldn't detect any significant difference between the drug and the placebo. In fact, the side effects were more or less just the same, so it didn't seem that that drug actually had any effect in humans, whereas it did seem to be really, really good for rats. Another trials were supposed to be ongoing, but we've not heard a word about this compound in 6 years. So we assume, although we've not been told, it's been combined to the scrap heap. However, there is another sodium channel blocker which is much more interesting, and this is the important work here. Important thing to look at here is the response in trigeminal neuralgia. This is placebo. This is number of paroxysms per day. Not really affected by placebo, and this is the active compound reducing the number of paroxysms to 2 or less, and this is the severity of pain, and again placebo not having much effect, and this new sodium channel blocker having a really good effect. That's called raxatrigine, okay, and that's as effective as carbamazepine, and it seems to have a lot less side effects. Of course, it's going to be more expensive, but its phase 2 trials have been completed and phase 3 trials are ongoing. A bit disappointing in lumbar radiculopathy because there was a very significant effect, but the effect size was very small and that there was only a 1 point in 10 reduction in pain. But the TGN trials are much more encouraging and shows a good response. So we expect to see this as a new kid on the block in the very near future, and that'll be nice to have a new drug to play with, at least for trigeminal neuralgia, and certainly for some shooting type pains in neuropathic pains. Mirogabalin is a very interesting drug. It's being investigated by Ichi Sankyo. It has a gabapentin-like action. Like gabapentin, nobody quite knows exactly how it works. Certainly, it seems to have much less side effects, and it's got in phase 3 trials on diabetic peripheral neuropathy and postherpetic neuralgia and fibromyalgia, which all started last year at various times. And it's certainly very promising. I think the biggest problem with this company is they don't have a lot of experience either in research or marketing, and they seem to be very slow in getting this up and running. So I'm wondering if they may sell this to one of the bigger hitters like Pfizer and get that off the ground. And we certainly it seems to be a very interesting drug, which from its side effect profile alone would be very welcome. Anti-nerve growth factor, well, this is controversial, and of course it's very expensive. And you know that in 2010 there was a great study in knee pain which showed the analgesia was so good that the patients actually self-damaged and they had to take them off it because they wrecked their knees. So there's still trial work going on. This is one of these great conundra. It's always thought to be the big breakthrough. And in 2015, they looked at 10 drugs which would change the world at the beginning of 2015. And this drug, which Johnson & Johnson had, fulranumab, was thought to be one of the 10 blockbusters. And then last month, they swept the one-time heavyweight contender out the back door without a comment. So they've given it back to Amgen, who they bought it from in the first place, and they've decided that further research is not worth the money that they'd have to spend on it. So years of trial, years of expenses, and it's out. But of course, the thing is, it's a potentially good drug, and there are other anti-NGF drugs which are still being used, and we'll see what happens to them in the moment. What about anticonvulsants? I think we've got a slide out of sequence here, but we might come up with another one. Anticonvulsants, many new anticonvulsants have been very disappointing. This is possibly one of the better ones. It seems to have a multiple number of names. Potig is the simplest one for me, or Trobalt. And that came out, and that seemed to have an effect in epilepsy, effect in nerve pain, modest, and a lot of side effects. And the company announced last year that they weren't going to make it after June 2017. So that looks like that's another blind alley. And then we got the MAPK inhibitors, and that's another compound which has been was published, a trial by Anand in 2011, showing a statistically significant reduction in pain scores during the second week of treatment in patients compared with placebo. It was well tolerated with no clinically relevant safety findings. But again, that's in 2011, and there's not been any trials announced since then. So where's it gone? It's 5 years. So it's a bit disappointing, and I need to catch the guy and say what's happened, or catch the company and find out what's happened to that drug, because it isn't as we expected. We certainly would have expected to have heard about it by now. What about the drugs that we have at the moment in that pathway that I showed, like Botox, capsaicin, tapentadol, and cannabinoids? We know that Botox inhibits ACH release at the neuromuscular junction, but it has a lot of other actions as well, which are really interesting. We know it can be used in chronic migraine now, and there's good reports. I'm going to show you in a minute some more reports on trigeminal neuralgia. We know that it has an anti-allodynic effect on animal models of neuropathic pain. So there is something that's really interesting. We heard 5 years ago there were going to be all sorts of novel mixtures of botulinum toxin, chimeras, and so on and so forth. And again, rather disappointingly, nothing has come to the marketplace. But Turo did actually present a review of its use in trigeminal neuralgia, which of course is a really bothersome condition. And actually, what he was looking at is the use of Botox for patients who were not suitable for surgery, who'd failed carbamazepine. And this is a technique where you inject up to 20 areas in the face with small amounts of botulinum toxin. And there have been 4 trials on these, all showing not much effect at 1 month, but usually very good effects at 3 months in stopping or reducing the trigeminal neuralgia. So these are the sorts of pictures that you get. That's the placebo injection, and that's the botulinum toxin injection. Different dosages don't seem to have too much difference in effect, but again, a very significant difference over placebo. So there's a compound that possibly is not very practical to use in many, many people, but perhaps we should be using it more in some people with localized neuralgic pain or neuropathic pain where the treatments have failed. And we don't think about it, but certainly it's valid statistically in these trials. What about capsaicin? Well, you all know about capsaicin. I'm sure many of you have used it. This is David Simpson's first trial on it, showing the difference between placebo, and there is a difference, but remember that this is a small change. This is an effect size of about 2 in the visual analog scale of 10 in the patients on the whole. So there were some very good individual benefits, but not in everybody by any means. And the number needed to treat has been revised down to 10. So you have to treat 10 patients before you get one therapeutic effect. So that means it's an expensive treatment. So it's probably not a treatment that we're going to be using on lots and lots of people. This is a little Cinderella drug. This is tapentadol. This just shows it's equianalgesic with oxycodone, but it had a lot less side effects, especially GI side effects. And it has a lot less addictability and a potential for abuse. So this looks, on the face of it, a really good drug, but doctors haven't used it throughout Europe or indeed throughout America, where you would think it was blind as a bat that you should be using it. So this is interesting. I'm not quite sure if that's because the expectation in clinical work doesn't come up to the trials or not, but it's perhaps something, given our problem with opioids at the moment, we should actually be revisiting, because it certainly in the trials has a really good effect in neuropathic pain, and there are very good hypothetical and clinical research support of that concept. Okay, so when we go through all those and we come out with our grid, we found that, yeah, there is a sodium channel blocker that we hope is going to come out. The work on anti-nerve growth factor is ongoing, and I think will take 4 or 5 years yet. You can decide on Sativex. Mirogabalin, I think, is really exciting for the future and one I want to look at. MAPK inhibitors, again, there's all the theories there, but not much in the way of clinical drugs. Tapentadol we should be looking at, and botulinum toxin we should be looking at. And I put capsaicin in rather faint there because it's pretty expensive and hasn't got a high efficacy rate. We forget the biopsychosocial model, and we try and treat with drugs and in blocks sometimes. So just because it's neuropathic pain doesn't mean we can ignore this. We need to assess them for that. That's a slide I show with great affection, because this is David Niv's sons. This is Tamir, his young son. Apparently Tamir is about 1.9 meters now and in the army. So he's grown up a bit. And he's got to take his puppy in to have a shot. And he knows that this is going to be really painful and it's going to be really upsetting for the puppy. So he's very upset. Here's the distress, here's the pain and the anguish, but nobody told the puppy. Okay? So the puppy didn't know it was going to hurt. So the biopsychosocial model, Tamir hurts, but the puppy doesn't. And we need to remember that. There's good evidence that there are psychological comorbidities that are frequent in chronic neuropathic pain, and the importance of pain coping strategies and catastrophizing has been highlighted by Haythorne-White. What about prevention? Yes, we need to do that. We need to prevent stroke. Well, we can't do that as pain specialists, but we need to promote the fact that it needs to be done. Acute stroke needs to be managed better. Spinal cord injury, actually strokes have come down, so that's good. Spinal cord injury hasn't, because young people do crazy things, like jumping into empty swimming pools when they're drunk, crashing motorbikes. But we can actually try and promote better initial treatment, which does seem to help. Acute shingles, we need to reduce the incidence of shingles, and we need to treat it well when it has started. That's beginning to happen across Europe. And diabetic peripheral neuropathy, we need to stress better control of glucose levels to stop the onset of diabetic neuropathy, which is a horrible condition because it just gets worse and worse. And we need to treat better HIV and AIDS from the consequent treatments of problems of pain which occurs in it, which often gets ignored. And in general, we need to permit to promote a fitter, healthier lifestyle. And I was glad to see when I went to Tel Aviv, people jogging, people running, and that needs to be encouraged. People need to get slimmer. They need to have healthy habits, eliminate sugar, and we can even look at gene therapy. So that's the summary. Preemptive prevention, early identification of neuropathic pain, treat the cause, serial trial of medication, slow titration, combinations in minimal doses, occasional interventions, always biopsychosocial, and always promote self-management. And I did tell you I'd show you something about the increasing incidence of obesity in people as time went on, and this is a slide which was taken from Jesmond Berkan's balcony back in '94, and you can see all these young men here, all nice and slim, and in fact, Elon, of course, I'd hate Elon because he stayed nice and slim, but you can see my tummy now. Enrique Rieg, I can tell you, he's put on a few pounds. This is the great and good of pain medicine on Jesmond's balcony, including Louisa Jones, and there's Ron Melzak, there's John Lozier, all getting together to discuss pain and its management. And now here we are, 22 years later, a little bit wiser and certainly a little bit heavier. Thank you very much for listening.